Excellent. Thank you so much. I mentioned this at the very beginning of the session. I'm notoriously terrible at remembering to record. So I just started recording, but hopefully we'll capture the majority of this session. So thank you so much, Dave. Jamie and Millette. Hey, Millette, I'm so happy to see you. Thank you for joining us from Overlake this morning.
Yeah, thanks, Gabby. My name's Jamie Boswell. I have been a hospitalist here at Overlake for almost 17 years, which is just hard to believe. It feels like yesterday in many ways. I'm joined by Millette Asmuth, who was seated in that room just a couple of years ago, going through the R2 Professional Development Day. So she's kindly agreed to join us. Overlake is here in Bellevue. It's a 349-bed hospital. We do not cover all of those as the hospitalist group, thank goodness. We are very much a community hospital setting, just one site that we practice at. We have 7 rounding teams per day, nocturnist and swing shifts, and some APP assistants for those late after hours. And our ICU, we have 24/7 in-house intensivists. So I would say it is relatively closed as I guess if we had to have a binary designation there. But yeah, no, it's been a terrific place to practice. I keep coming back, 17 years strong. I could look forward to many more. And I'll let Millette chime in with her perspective on having come here too.
Yeah, so I'm Alan's class of residency. So I just finished last year and started Overlake at the end of August. And Jamie kind of gave the long and the short, but I'm happy to answer any questions. I think it's easier for me to compare to UW since I'm just fresh out of residency. So I look forward to answering some of your questions later.
Thanks to both of you. And I think it's just so nice to have folks at a range of places, stages of their career, because I think that's really helpful to get those different perspectives for our residents. Nancy, can I invite you to go next?
Good morning, everybody. Happy to be here as well. I'm Nancy Marshall. I'm from Evergreen Health in Kirkland, entering my 20th year of practice there, and went there from the University of Washington residency. So I was sitting in all of your shoes as well, know very much what it's like. Evergreen is a community hospital, growing quite a bit recently. It's a 380-bed hospital. It has an open ICU. Recently, we've put quite an emphasis on stroke care and lots of interesting and new stuff, actually in partnership with Jamie's hospital at Overlake. We have a consortium of things that we treat mutually. I think the reasons why I came were I liked the diversity of diagnoses. I liked the open ICU. I was someone that liked a lot of procedures at the U. And we have 50 people in our group. I think what I really liked about my group is it's pretty fluid in terms of FTE. We usually ask people to start at a 1.0, but most people usually vary up and down during their career. And I found that to be advantageous for me. I'm 0.75 now. We have 3 APPs in our group that do mostly admitting, also at night and during the day. But I've really loved the diversity and as the group's grown, many different colleagues at various stages in their career.
Wonderful. Thank you so much, Nancy. Who's next on my screen? Frank. Dr. Louie.
Yes, sorry, everyone. I'm in a clinic computer, so it's showing up as Dr. Louie. Yeah. So yes, I'm Frank. I have been at UW Montlake as a hospitalist for the last couple years. And prior to that, I did my training over on the East Coast at Beth Israel Deaconess, where I was a hospitalist there for a year as well before coming out here to UW. I can definitely give perspective if anyone is interested in kind of what the East Coast is like, or Boston in particular. And while over there, at Beth Israel, I also worked at a couple community hospitals, but mainly at the academic center. So I do have a perspective on the comparisons between an academic center versus community hospital as well. And here at UW Montlake, and actually at any of the UW hospitals here. I am in clinic, as you can see in this setting. So I do half of my time in the medicine consult side, so doing preoperative clinic as well. And that's some interesting opportunities to do other things outside of just pure hospitalist work, which is nice for the variety. You guys are very well familiar with, UW Montlake patients and what the structure is like. But as a hospitalist, it's the different shifts are just, rounding, and then we have swing shifts. There are some people that do nights as well. And so it's a very flexible schedule. A lot of people do a lot of outside clinical work as a hospitalist here. There's an abundance of opportunities and flexibility for doing that.
Great, thank you, Frank. Just a note for the residents, it's really tried to be quite intentional about not just having a lot of hospitalists from hospitals that you're already familiar with. I think it's really great to have Frank representing sort of the UW hospital system and what that is like, but really wanted to use this opportunity since you may have less exposure to folks in different hospital systems. Wanted to make sure that we heard those perspectives as well. So thank you, Frank. Sierra, so nice to see you.
Hi, good to see you. I'm happy to be here. So I'm at Providence in Everett. I realize I don't actually technically know how many beds it has, but I can tell you at the height of Omicron, total inpatient census was over 600 at one point. Of that, the hospitalist team, I think our all-time record-breaking inpatient census was like 417 or something. So we are a very big group. Our census now averages like 320 to 350 patients. And for that, we have about 80 hospitalists, about 8 of which are nurse practitioners. It is a closed ICU, though we have incredibly high acuity on the floor. So definitely patients that in residency would have been in the ICU, we take care of on the floor at Providence. I have been here for almost 2 years now. I finished residency at UW in June 2020. Let's see, what else did we talk about? The schedule is not 7 on, 7 off, which is one of the draws for me, is that there's flexibility there. There are a handful of us that do 7 on, 7 off, but most of us decided we did not want to do that 7 on. So there's options there with your schedule. I think that's all I'll say for now.
Great. Thanks, Sierra. All right, so those are our 6 hospital systems that are represented this morning. Appreciate everybody doing that intro. I'm going to ask a couple of questions that are really common. And then I'm going to open it up to the residents for Q&A. Okay, so residents, think about your questions that you want to ask. And remember, this is really meant to be a safe space for questions. So if it feels challenging or hard to ask a question, I think I can vouch for all these wonderful people that they're happy to take your questions, but you're also welcome to send them to me anonymously. Okay. One question that comes up a lot for our residents who decide to leave UW is what kind of teaching opportunities you might have at your different hospitals. So I'm wondering, just go ahead and maybe if you know how to use the emojis on raise your hand if you have, there you go. Thanks, Ira. If you have teaching opportunities or want to talk about teaching opportunities. Dave, go ahead.
Yeah, at Swedish, we have kind of a number of different teaching opportunities. I'd say the majority of our group do not participate in teaching opportunities, but there's definitely options there, which I think is kind of a nice way for people to kind of re-engage with teaching and learning when, they feel so inclined, and to kind of back off if they feel like they need a break or just kind of want to tone things down a bit. We have a Hospitalist Fellowship that was started in 2008, and it's designed for family medicine trained physicians. I've been the fellowship director of that since 2015. We have 3 fellows per year. So we have 1 fellow on at our First Hill campus 365 days a year. And so there's one designated teaching attending that works with the fellow. So they have a decreased patient census, and to be able to spend some time with the fellow and run through the patient list. They don't see all those patients in person, but they do work with the fellow very closely and do teaching there. We, as many of you probably know, we have an elective for UW internal medicine residents, 2nd and 3rd year. And so they are also working with that same teaching attending. So teaching attending might have a couple of different learners they're working with. They're always working with the fellow. Often one of you guys, if you're coming to visit and hang out with us. And then we also have a collaboration with Washington State University Medical School. And so a lot of people are onboarded as clinical faculty and teach 3rd and 4th year medical students at both our Edmonds and First Hill campuses. So these are all kind of opt-in options. And so people that are excited about teaching definitely can get plugged in and do it quite often. In fact, maybe half the time you're on, if that's something that's interesting to people. And other people opt not to, and some people kind of go back and forth. So definitely a variety.
Awesome. That's super helpful, Dave. Thanks so much. Nancy.
Yeah, so we teach 3rd year medical students from the U. Scott Stewart, who you may know, runs that program, and we've had it going on at some level for about 8 years now. There are 3 rotations of 3 students each from the university during the spring, summer, and fall months, and it's a great opportunity to either be a one-on-one preceptor for the medical students or to do teaching lectures. I'd say that about 1/3 to half of our group participates at any one time.
Fantastic. Thanks, Nancy. Alan.
Very similar to Swedish, our teaching opportunities are also on a volunteer basis. We have one service, one track that our hospitalists rotate through as well. We have a family medicine program, and that's mainly our teaching opportunity through that. It's not our traditional rounds that we normally experience at the U. The family medicine residents at the Valley have to do pediatric rounds, OB rounds, and then an internal medicine round. So it's kind of a very different structure, but they carry about, I think, 5 to 6 of your patients, usually the more interesting learning cases, and then you're responsible for the resident teaching and also patient care at the same time.
Perfect. Thanks, Alan, and thanks for that comment, Dave. And Jamie and Millette.
Yeah, thanks, Gabby. Yeah, I would say at Overlake, we're certainly not a teaching hospital per se, but I think one of the nice things, and this is medicine, we all know this, right, is it's fun to give back just as people gave back to us. So we get lots of asks we currently right now have a physician assistant who's doing a rotation following a couple of our partners. We have had ARNP students similarly that'll come on board. We have people who are in college and want to be, a PA or ARNP physician, and they'll just reach out and we'll try to give them good shadowing opportunities. So it's kind of fun. I think just like a lot of things in life, some of us really like having students with us on rounds and having that fun academic dynamic, and others feel less compelled and find that, less appealing to them. So yeah, certainly not mandatory. It is very much a voluntary issue, but it's really fun. I think it's really fun. And it's nice. We usually have somebody of some discipline floating around within our office and out on the wards with us at various times.
That's great. Thanks, Jamie. Yeah, and I think I want to just really echo that, right? I think as residents, you've just spent 4 years in medical school, maybe longer. You're spending 3 years in residency, a very academic residency. And so I think it can feel jarring to think about leaving the academic environment. And yet we know that that's what many people want to do or want that experience. And some people want teaching opportunities and others don't. Some people want teaching opportunities without all this sort of like pressure and trappings of the academic environment. And so really want to highlight these different types of opportunities at different spots. And Sierra.
Yeah, I can't believe I forgot to say this when I was doing the intro. So we actually just started a residency, an internal medicine residency in conjunction with WSU. in 2021. So right now, all we have are interns, and we're getting our second group coming in this July. So working with the residents, and then there's also medical students both from WSU and from the University of Washington on those teams, and doing wards as we are used to it is entirely voluntary, but highly encouraged. And then the part that's not so voluntary is part of our job, if you work days, is you'll do 2 to 4 swing shifts a month, maybe. And if there's a resident or residents on that swing shift, then the expectation is that you work with them. So you cannot entirely opt out of teaching with the residents, but you can definitely choose the extent to which you're involved. And because it's such a new residency, there's still a lot of opportunity to be involved in formulating what that residency looks like, which I find really cool. And I'm not sure if this will continue to be an option, but I know one of my hospitalist colleagues wanted to do something else besides work with them on wards. So she actually is one of the clinic attendings with them, which she finds, you know, obviously just an entirely different skill set, gets her out of the hospital and back into the clinic. And they actually, the attendings in clinic for them do not have their own patient panel. So their job is 100% just staffing with the residents, which is kind of cool if you don't want to have to worry about an in-basket, but want to do some clinic work.
Don't tempt me, Sierra. It's okay. Sierra and Alan were at Roosevelt Clinic with me, so they know the in-basket pain, as you all do. All right. So I know that that's a very common question around teaching. There are lots of other common questions around flexibility of scheduling, what you like about your schedule, starting salary, seeing opportunities. So I have a lot of questions that I could pose, but I want to pause and actually see if there are burning questions from our residents. Anybody feeling brave want to ask a question? Not necessarily, no brave soul.
This is like a bit of a general question, and I'm not sure if this is appropriate for here or would have been appropriate for the fellowship one. But I know a number of us are probably looking to, you know, do a hospitalist year and then apply to fellowship.
Yep.
And I think some of us are a little bit worried about, you know, moving out of the academic hospitalist groups and into kind of more private practice hospitalist groups, and how this would affect like moving on to fellowship. How is that typically viewed? And, you know, if you guys have had coworkers or some experiences with people, like how did they kind of incorporate a private practice setting into kind of their future fellowship, you know, I guess, application? Yeah, that's a great question. Well, I'm going to maybe say a couple of things. One, I think that specific question about doing community-based practice before coming back to fellowship is a good question for Lisa and Radhika. But I think for this group, what could be particularly relevant is how is it perceived? Because this happens, and so this is a good place to ask hard questions, right? How is it perceived if somebody is, you know, planning to do hospital medicine work for a year or 2 or 3 before going back to fellowship? And how does that feel as a hospitalist group? And we appreciate your honesty.
I can start on that. That's a hard one. You know, I think it depends. So we have had people come in and stay 2 or 3 years because their spouse was training and they're particularly good candidates, and we really wanted to have them and thought it was a great learning experience for our group. So we hired them. Full knowledge that they were going to leave in 2 or 3 years when whatever they were planning came to fruition. For the most part, though, we are looking for career hospitalists, I think, and we don't, as I said, we take each candidate or applicant individually, and so I can't make a blanket statement that we wouldn't consider people who are wanting a short-term stint as a hospitalist. I just think most of us would want to hire someone that wants to be career hospitalist.
Thanks for that, Nancy, and appreciate your honesty. Jamie and then Sierra.
So thanks. Yeah, no, it's a great question. It comes up every year when we do this, and that's appropriate. I think for us, I always say recruiting is about finding the right people for the work that we do. And sometimes that means that they're not here terribly long, you know, and I guess I would say, I think it is really helpful and just good in terms of relationship building that you let your future employer know that. And, you know, if you're really thinking I'm going to go be a cardiologist in a couple of years, I think it's just good to be upfront about it. Recruiting takes time. It's a lot of work and investment on the part of the employer. So it doesn't exclude you at all from being considered for these positions, but I think it's just helpful to know kind of that's your process. And I would say this, I would say be forewarned. We will try to convince you otherwise once you get here. And we will onboard you in the same ways we onboard everyone else. We will think of you as one of our partners, and we'll try to convince you of the merits in staying in hospital medicine long term. So,
thanks for that, Jamie. Sierra was next, and then David.
So I will say our medical director is very understanding that life plans change. That being said, we are definitely looking for people who want to be career hospitalists, who you know, want to be a long-term member of our group. And I think that is shown. I saw in the chat, there was a question about turnover. I don't know the exact numbers, but our turnover is pretty darn low. Recently, the only people that have left, two of them, it was for family reasons that they ended up moving back to the Midwest. And then one did realize that her heart truly was in primary care. And so I know, Gabby, it made me think of you. So she decided after about a year being a hospitalist to go do that. But I agree with being completely honest if your plans are short term. But that being said, if that's the case, Providence may not be a good choice for you.
That's helpful, Sierra. Appreciate that. David.
Yeah, I would echo what other people said, that I think that, you know, at Swedish, we really do pride ourselves of having a very low turnover and a really, you know, good core group of people, and, you know, creating that culture and that environment and that group that's cohesive and is, you know, I think having some longevity to people fosters that. So, you know, I wouldn't say it's like out of the question that someone would potentially be hired if they're thinking about doing a fellowship. I think, you know, I applied to Swedish saying I was kind of 50-50 on doing fellowship and got hired and didn't end up doing it. But so I'd say, you know, like some of these other groups, we're mostly looking for people who want to be a hospitalist, but it's not totally out of the question.
Thanks, David. And Frank.
Yeah, certainly here at UW, we are here to support our medical residents in whatever career path they choose. And so mainly our turnover has been people who have, you know, go to fellowship after a year or a couple of years, or even there have been several who have been hospitalists for, you know, 3 to 5 years and decided they want to, you know, do palliative care or something like that as well. Where I did my training at Beth Israel, it was very common to have people from residency do, you know, come knowing that they would be leaving in a year or two and be upfront. And I kind of get that sense at academic centers. This is kind of a bigger trend, that they are a little bit more willing and accepting to hire people knowing that, you know, they may leave in a year or so.
Thanks, Frank. And I see Alan echoing, which is great. Okay. I hope that addressed in some ways Jordan's question about turnover. And if not, Jordan, happy to circle back to that. Getting a few other things for questions. So I'm going to go ahead and share some of the things on the residents' mind. Can folks speak to contracts, not necessarily the nitty gritty, but do your hospitalists typically sign annual contracts, or is it a multi-year kind of deal? Nancy, go ahead.
So we negotiate the contract as a group, and we sign a 5-year contract. That being said, there are clauses in the contract that say if something doesn't work for us, or if something is that admin wants to change, that we can come back to the drawing table and just talk amongst ourselves about what the best solution for things will be. So while it's not set in stone, it's usually about every 5 years.
Great, thanks, Nancy. David?
Yeah, I think we used to have a term limited contract, and recently it's shifted over to kind of open-ended, and so we can, either side can kind of reopen the negotiations, but the contract as it stands is kind of just ongoing, and it has a kind of a clause to peg the salary to certain percentiles so that it doesn't necessarily need to be revisited super frequently.
Perfect, thanks, David. And I see folks chiming in the chat around annual contracts. Okay, I'm going to segue to another question that had come in, and ongoing for contracts for Overlake. Thanks, Jamie. So I know salaries are on everybody's mind, and nobody wants to be the person to ask it. And so I'm going to ask that on your behalf. So panelists, I'm going to ask you to share, to the best of your knowledge, you may not be the hiring person, what a sort of typical starting salary is for a hospitalist, a full-time hospitalist in your group. That's number one. And then the second part of that question is really thinking about sort of balancing well-being for your colleagues, the hospitalists in your group, thinking about paid time off, parental leave, things that may come up that are unanticipated, and how you support your hospitalists in those moments. And also see a question about salary growth for career hospitalists, which is a great question. So maybe we'll start with the salary question. And so if you could share, to the best of your knowledge, a general starting salary and any sense of career, like salary growth over time.
I'll go first.
Thanks.
So I will say, so a 1.0 FTE hours wise, just so you can get a sense of that, it depends on how many years you've been there. The first year is a bit more. So 1.0 FTE is 2,022 hours. And then years 2 through 5 are 1,980 hours for a 1.0. That being said, we realize a 1.0 FTE is not for everyone. And so the expectation is not necessarily that you start as a 1.0 FTE. If you want to start at a lower FTE than that, that's acceptable. And the salary target, the first year is basically guaranteed, because we understand that it takes time to build efficiency and everything, is 302,000. Did I say that right? 302,000. And after the first year, it goes to about 50-50. If 50% of that is salary based, and the other 50% is productivity, which is both RVU based and also patient contacts. There's a whole formula that goes into figuring that salary out. Also, every year there are certain quality metrics that if the team meets, we get a bonus. You get paid project hours. So when you take part in committees or do things that are part of the job but outside your normal hours, you are allotted a certain number of hours a year that you get paid for that work that you do in addition to your salary. And then I can't remember the exact number, but I think it's $3,200 a year or something for CME that does roll over for 2 or 3 years if you don't use it all in 1 year.
Thanks so much for that, Sierra. I'm just going to go in the order of folks on my screen. I see Jamie next, Jamie and Millette.
Yeah, so I've only been here 9 months, so Jamie can answer the longitudinal questions, but the salary structure is there's a base daily rate, and then we are RVU based, and the contract specifies for full-time. So I'm 1.0 FTE. I work 165 shifts a year, and I'm strictly days except for 1 shift a month on average is a swing shift. And then there's a separate person who's hired for the nocturnist shifts, and they're actually switching so that I will no longer be doing swing, and there's going to be a swing shift person. The salary is equal for the hospitalist group, so it's flat across the board, which I liked coming out of residency. I guess there's not negotiation room per se, but as the group can negotiate kind of the rate, and Jamie can talk more about how that's done when they negotiate the ongoing contract. But coming out of residency, there's not a lot of work required on your part to feel like you're getting paid equitably based on your training or your gender or whatever. So that's something that you guys will get in your third year career day. And then there's a percentage of the salary that is the bonus, and part of that bonus is group-based, based on meeting quality metrics for certain targets that the group has set. And then the other part is your citizenship bonus, which you can meet based on attending the meetings for the hospitalist and the hospital groups, as well as doing some kind of QI or other, hospital group involvement.
Okay, we need a number though.
Jamie has the average, because I've only been
here. Sorry, I'm gonna ask the hard question.
We see how we tried to sneak out of that.
I know, but these poor folks, they want to know. They've been working nothing for a long time.
And I think if I give you last year's number, it will be higher than usual, and that is reflective of what Millette said. We have a lot of our compensation is RVU based, and let's face it, everyone on this call can attest to last year being a stunningly busy year. And we like the fact that our compensation model accommodates to that at some level. So most of our full-time docs pushed up to about 350 last year. There's a range. It just depends on how busy you are. But nonetheless, that's kind of a rough number for where we landed last year.
Super helpful. Thank you, Jamie. All right, I'm going in. Nancy was next.
Sorry, having trouble unmuting. So yeah, we have predominantly salary-based compensation, but we have many components of that on top of the base salary. Our base salary is linked to a COLA, a type of COLA, which is, we are King County Hospital number 2. Some of you guys may not know that, but if we get a general increase for everyone that works at the hospital, then the hospitalists get that increase as well. So if it's 1% for the year, we get that. If it's 3% for the year, we get that. And that allows us to remain competitive based on, even if we've negotiated the initial contract 5 years prior. Our base salary is $343,000. On top of that, we get a group production incentive, which is if we see more than 15 encounters on a daily basis, and an encounter can be a central line, it can be another procedure, or it can be a visit, then we get a pool of money that's put in and divided based on FTE doled out to everybody at the end of the quarter. In addition to that, if you work on committees, you get an hourly rate. So if you're doing something to promote a pancreatitis protocol that you want kind of made popular in the hospital, you do all of the work for that. And for each hour, you get an hourly wage. It's slightly lower than the clinical wage. It's hovering around $150 an hour for committee work. In addition, we have really generous PTO. We have 4 weeks total of PTO, 1 week of CME, and you get an additional week on your board's recertification. Each one of those weeks, if you would want to structure your schedule this way, can be a 3-block week off. So your PTO is not counted in the week on, week off if you're using that structure. The total number of shifts for an FTE is 147 for a full-time. There's also a risk structure. So each full-time FTE is responsible to be a backup physician for between 11 and 13 shifts a year. So it comes out to be really similar to what Jamie was speaking about, I think, for his group. Yeah, I think that's the majority of the detail.
Thank you, Nancy. That's super helpful. Thank you. Alan.
At Valley, our 1.0 FTE is about 168 shifts for per year for a daytime hospitalist. It's going to be, I think, a little significantly less than that if you are a nocturnist. Our base pay is roughly about $320K. We recently just got a pay raise, and our contract is negotiated every couple of years based on kind of hospital profit. And if the hospital does well, then we may get a little bit of a pay bump. And it's been, I think, 3 or 4 years since we got a pay bump. And I was lucky enough to start the year that the whole team got a pay raise. I think that's mainly it. I don't remember what else I need to answer. 320K, 168 shifts a year.
That's great, Alan. If you have other thoughts, you're welcome to throw them into the chat. And Frank. We're going to depress everybody by telling you, nope, you got to unmute, Frank. We can't hear you.
Yes, academic hospitalists tend to make a lot less than any academic center, as coming from one. So base salary here is just a little bit over 200,000. This is actually a little bit higher than if you were in Boston, it's even less than that. And so it is out of 168 shifts a year. Nice thing about here is, you know, if you are sick, you get paid. There is no max amount of sick days you can take. We have a really good backup system for that. This is in comparison to my previous job as a hospitalist, where if you was purely your salary is basically purely shift based. So you get paid a certain amount for each different type of shift you make, and you basically tally up all the different shifts, and that's what you make. So this is kind of nice and flexible as, you know, things come up and people are sick or need for childcare. In terms of adjustments year by year, there's generally about a 2 to 4% increase per year based off of your salary. On your salary, they may call it inflation related, or if you're doing a good job. Pretty much everyone gets this type of little pay bump each year as well.
Fantastic. Thanks, Frank. And thanks for that in the chat, Alan. I will maybe just share my additional perspective on what Frank mentioned. Having been a hospitalist at the UW for 5 years before I moved to primary care, you know, obviously there's a pretty enormous differential between practicing in the academic center versus practicing in the community. I think you've gotten a sense of some of why that is. But I think what this will come back to is patient load, which was mentioned in the chat. And so one of the reasons that UW has always justified the salary is partly because some of those weeks you're attending, right? Where you're, however many weeks that is per year, 4 to 8 to 12, or, you know, depending on how many, what your FTE is, there's a significant number of weeks per year where you all, our residents, are, you know, doing a lot of the work. And the team sizes are much different at UW. So maybe that's a good segue into the patient load, because I know that was a question. And if folks feel it's easiest to put it in the chat, that's totally fine. But Nancy, so that's helpful. At Evergreen, the patient load is 12 to 17, including ICU, right?
Right.
So
we see, yeah, 12 patients if you're the teaching attending. Usually we start the day with between 13 and 14 patients, and we have 17. Recently, we've had, as Jamie will attest to because of the busyness of things, up to 17. We have a risk trigger system, so we don't, as a group, we agreed that 17 is a safety issue above that. And so all of us agreed to work on our risk days if we go above that. And when we do work on our risk days too much, then we hire more people. So it's kind of a nice trigger to admin that we're seeing too many patients if we are using those risk triggers too often.
That's helpful, Nancy. Thank you. Alan?
Very similar census to Dr. Marshall. Our ranges are anywhere between 12 to 17 per day. We are in the process of hiring for a full 14 teams per week. Right now, we haven't met that goal yet. So sometimes on the weekends, we are short a couple of hospitalists, which makes our census a little bit higher than normal and average, above average. But overall, our census pretty much falls in that range with an open ICU. So on average, you get about 2 or 3 ICU patients per day, in addition to your floor patients. Our nocturnists, we have 3 nocturnists who cover the whole hospital. So they are responsible for admitting throughout the night between the 3 of them, and also covering open ICU and cross-covering the whole floor.
Super helpful, Ellen. Thank you. Jamie and Millette?
Yeah, so I think our daily census has fluctuated dramatically. I think December and January were massive outliers, but on a typical day, I would say probably in the 14 to 18, but I definitely have had days where I've even gotten it below 10. But I think for the days that the group census was over 100, usually we have 7 rounders, and then in December through February, we implemented a surge provider where people could sign up electively for backup shifts with overtime pay rates, and people would just serve as the admitting provider for the day to kind of offload the busy teams.
Super helpful. Thanks, Jamie. David? And Millette, sorry.
Yeah, so we try to be pretty efficient with our staffing, and so our census is pretty tightly clustered between I'd say 14 to 16. We try not to go above 16. We see our discharge efficiency and other things start to drop off, and patient care starts to suffer, obviously. We do have a backup system, and so we generally have kind of on the leaner side of staffing, but then we have a backup that can get called in if the census is high. So that's kind of how we're able to not drop too much below 14 and try to be pretty efficient with how we're using our staffing resources. I didn't necessarily go through kind of the structure of Swedish, but we're scheduled for 172 shifts a year with 7 days of vacation that you can take off on any of those scheduled days. So it'd be 165 shifts per year. We're generally week on, week off, and we have some backup in there too. Our salary is currently $350. 80% of that is guaranteed. 20% is quality metrics that our hospitalist leadership group decides on, and they're generally things that we can hit, but that are useful for the hospital and the system. I don't think since I've been at Swedish for 8 years, we've ever not gotten the quality. So it's really just a kind of a way to focus the group rather than kind of a something that really is like a challenge to achieve. Yeah, I think that's about it.
Awesome. Thank you so much. Thanks, David. And Frank?
Yeah, so our hospitalist census caps out at 10. So you will never have more than 10 patients a day. And as you know, on the teaching service, it's also the same where you have 1 intern, 1 resident, and 10 patients. So it ends up being pretty relaxed. Just to speak on the medicine consult side, if you guys are interested, it's also probably even, I probably see maybe, I don't know, 8 patients a day. As you can tell, I'm on service now, and the really pros to being here is that you have time during your day at work to pursue other things, whether it's meetings or committees, so you can integrate that into your work day as well. Also in the med consult clinic, if you end up doing that, we only see 4 patients in a whole day, so you get ample time to see your patients, and you don't really take home work, which is really nice. So there's definitely a big pay discrepancy, but it's you know, work-life balance for that as well.
Great. Thanks so much, Frank. Okay, we have a little bit less than 10 minutes left, so just want to pause and see if there are any burning questions from residents that we haven't gotten to. And then
Gabby, I have a question.
Yeah,
For I was just wondering about the research opportunities for those who are hospitalists, because I know there's the teaching opportunity, but like those who are in research, if they can just like talk about that a little bit.
That's great. Thanks so much for bringing up that question. Does anybody have research opportunities at their institutions?
Yeah, I think that there is opportunity. We do have a research program. Our last year it was used mostly as part of the Act 1 and 2 trials. Our hospital was a center for those two studies. And that was led by an infectious disease physician, but you can be a part of anything that you're interested in at the hospital.
Thanks, Nancy. Dave?
Yeah, we have quite a bit of research coming out of our infectious disease group. I think when COVID hit, there was a lot of enthusiasm for participating in research. There were some like investigator initiated studies, but also collaboration with some of these multi-site trials. We're part of the PEDAL network and do sepsis related work that's mostly in the ICU, but some of that also does happen on the floors too. There's a pretty robust, the Cancer Institute has a pretty robust research process too. I would say not a lot of the hospitalists are directly involved in research, but if they came to Swedish with that background or interest, there certainly could be opportunities.
That's great. Thanks, Dave. Frank and Sierra, and then we have a couple quick questions. So I'm going to ask maybe to be brief with this one.
Yeah, clearly there's a lot of research opportunities here. You just have a lot of resources to engage in whatever type of research you would like. There are a few hospitalists who do, have a decreased amount of clinical FTE, so they can build a lot more research time as well. And the other big plug I want to say at UW here, they have a really great career development program here, better than I've seen at other hospitals as well, where they're really trying to help early career hospitalists kind of build their passions and just guide them through navigating whatever projects they want. It's just really robust that I haven't seen in other hospital systems.
Thanks, Frank. Sierra.
So I'll just quickly say, while I haven't personally been involved in any research, I know it exists because I know a few of the hospitalists have published recently. There's been a lot of infectious disease things. A lot of the new residents are working with specialists to do research. So I imagine there would be involvement in some of the specialty areas like oncology and things like that as well.
Thanks so much, Sierra. Okay, I'm going to do two things. There was a question to me about whether any of your groups outside the UW, so Frank, you don't have to answer this one, but other groups, if your hospitals are eligible for public service loan forgiveness, and you can just type that in the chat. Alan, it looks like you are, or you can give a thumbs up if you are eligible, if you know if your hospital is eligible for public service loan forgiveness. And then the last question is a great one that Nick posted. So Nick, thank you so much for posting that. So if people can look in the chat, for those who are particularly recently graduated, so maybe Millette and Alan and Sierra, what do you see as the pros and cons of your transition to community programs as opposed to staying in academics? What were you surprised by, if anything? So Millette, Alan, and Sierra, I'm going to pitch that to you.
Yeah, I'm happy to go first. So I think it's hard to leave the nest because that's all I knew, having gone to med school and then in residency you're only in academics. But I looked around and there was a prior graduate who was at Overlake before, and I really trusted her opinion. And I thought that coming to Overlake was really nice because I saw people that had been in the career for 15 to 20 years. And so for me, I saw that as a strong argument that it was a sustainable career. And I think that the group tries very hard to make it that way and to be flexible and to make changes. We're a smaller group than I think 40 or 90 hospitalists at the other institutions. And there's a lot of input that we can give if we're seeing things that are not working, like the surge was a new implementation during, the Omicron surge. And I liked also that there were opportunities for quality improvement, to do projects. It's really easy to get involved. I think the other advantage at Overlake is the consultants are really nice and very available. The hospital is very efficient, and the schedule is super, super flexible. So the blocks of timing structure are 3 and 4, and you can mix and match it however you want, and they build it around your time off because another hospitalist is making the schedule based on personal requests. So I think that I wouldn't say it's not specific, like I don't remember how the UW schedule is built, but I would say that specific to Overlake and being in the community, that's something that our group prioritizes. And then I also think there's a lot of opportunity to get involved in things based on how you want, but there's not requirements per se to do specific items. But if you want to do quality improvement, there's a lot of opportunities for it. And I just really liked the group. Yeah.
Thank you so much, Millette. I'm just aware of the time. We have 2 minutes left. Alan, do you mind sharing a little bit?
Sure. I think the biggest adjustment was just practicing on my own. I am always someone who looked to my senior and my attending for advice to kind of make the best decision for our patients. And I found that to be challenging when you're all by yourself. But our group at Valley are really cordial. We're always in the team room together when we're not seeing patients. So you have a ton of people to bounce ideas off of. And similarly to Millette, our consultants are all amazing. I've never had to fight for a consult. I literally just text my consultant and say, hey, have a consult in room 34, please go see. And then they just say, okay, and just do everything and put in all your orders. So it's a very different atmosphere, very different environment. And I think all of our goals are the same, which is try to take care of patients as safely, as efficiently as possible.
Awesome, Alan, thank you so much. Sierra, you get the last word on this one.
Okay, so I was pretty sure I did not want anything to do with working with residents, teaching, all those things of an academic hospital when I first left. And then kind of like with Alan, it is a amazing adjustment when you are the attending and there is no team, it is just you. So within like 6 months, I knew that I actually did want to spend at least some months working as a team again, and there is that option. Otherwise, we are a huge group, but also a very supportive group. You get paired with a mentor when you first join, who they try to match you based on like either you're kind of at a similar position in life or you went to the same residency, these kinds of things, so that you have one designated person to bounce things off of, but the whole team is so incredibly helpful. It's a really warm environment. Our medical director cares very, very much about your mental health. So there have been people that had to take weeks, a couple months off in the last couple of years for their well-being, and he will figure it out, which I thought was awesome.
That is so helpful. Thanks, Sierra. Thanks to our recent grads. So fun to see you all here and in your new roles. And thanks to our more seasoned hospitalists for joining us as well. Your perspective is really invaluable. And I think that's something our residents don't often see is the longitudinal nature of this work and how it can be such a meaningful career for so many people. So really, really appreciate that perspective. We're probably going to get a little pop-up that says we have 1 minute left. And let's see if that happens. Yes, we got it. I got it. 1 minute left. Panelists, again, thank you. For residents, I'm going to record the second session as well, because inevitably there may be different questions that come up or different perspectives that are shared from our panelists. And so we'll make that available to you as well. Residents, you all have a 10-minute break before we restart the panel, the second panel. Thank you again. Panelists, thank you, thank you, thank you. You are absolutely wonderful people for doing this. You can just turn off your cameras. We'll keep this breakout room open. We'll restart at probably 10:44, give everybody a full 10-minute break, and see you soon. Hey, Jordan, anything I can do to help?
On how well he rows, he may row for nationals, which is that same week.
Okay.
Of the R3 retreat. So if he makes it to nationals, then I'm going to go to Florida.
Okay.
But if he doesn't, because he's only 15 and he's
Well, that's not the attitude I want to hear, John.
no, sorry, he's 14 and he's competing with a bunch of 16 and 17-year-olds.
That doesn't sound very supportive. Gabby, I think you still have your record on. I think
Yep, I did. There we go. Okay. And I'm going to let our residents filter in. So this is great. Thank you. Might have a slightly smaller group this time, which is great. Hopefully that allows us to make sure that we get to everybody's questions. For the residents, I hope you had a productive conversation in your first panel this morning. So welcome to Hospital Medicine panel. We have 6 hospital groups represented this morning and had a great discussion during the last hour. So really appreciative of everybody's time. I'm going to ask each of our hospitalists to introduce themselves and their practice site. I think what I learned from the last time was maybe to let folks know how long you've been in practice, whether you have an open ICU or not, and anything else really distinctive about your practice site. And then residents, I have some questions prepared that people usually ask about or that I know are on your mind. And so I'll be prepared to ask questions, but actually really want to just open it up for Q&A. So if you have questions, please feel free to ask those. I had several folks send me a couple of private chats last session, and I'm happy to ask those questions on your behalf. Okay, but I can attest to this being a really wonderful, warm, and safe group. So feel free to ask questions that are on your mind. Sierra, it looks like you are first on my screen this time. Oh, Sierra, we can't hear you. Which it looks like you're unmuted, so that seems odd. Let's try again.
Can you hear me now?
Got it.
Okay, sorry about that. So I'm Sierra McCreary. I finished residency at UW June 2020, and I've been at Providence and Everett since. It's unique in that even though we work at Providence, I will say we actually work for the Everett Clinic, who then contracts with Providence. So that's kind of an odd thing about us. We're a very large hospital. I don't know the actual number of beds, but at the height of Omicron, there were over 600 inpatients. 420 of those were on the hospitalist service at that point. Our team now ranges more 320 to 350 patients. We have a group of about 80 providers, about 8 of whom are nurse practitioners. Closed ICU, though incredibly high acuity on the acute care floor, definitely more than I was used to from residency. Anything else, Gabby?
I think that's a great start, Sierra.
Okay.
Yeah, thank you. We'll come back to other questions that folks have. And residents, feel free to put questions in the chat also, so everybody can see the chat. All right, Nancy, you're next on my screen.
Good morning again, everybody. So I'm from Evergreen Health. My name is Nancy Marshall. I have been at Evergreen for starting my 20th year. Evergreen is King County #2 hospital. So it's quite diverse in terms of the types of patients we see. 380 bed hospital. It is an open ICU. We have 50 hospitalists on my team. 3 of those are APPs, and they admit at night and during the day as physician extenders. And we have 11 rounders total. That's something I forgot to mention on the last panel during the day.
Great, Nancy. You know, I'm not sure that everyone knows, all of our residents know what King County #2 means. Do you mind sharing?
Sure.
Oh, I think we lost your mic for a second.
Can you hear me okay now?
Yep, got it.
So some of you may not know, but Harborview is King County Hospital #1, and Evergreen Health is King County Hospital #2. It is, even though it's in Kirkland, in the confines of King County. It means that we are partially kind of administered by a board that's elected by people within the county. So the constituents that we serve elect our Board of Commissioners, and that's how we are run.
Thanks, Nancy. Appreciate that. Okay, let's see. Frank, you're next on my screen.
Yeah. Hi, my name is Frank. Sorry, everyone, that my name shows up as Dr. Louie. I'm in using one of the clinic rooms in the hospital here. But I am one of the hospitalists here at UW-Montlake. And I have been here for the past 2 years and previously did my IM residency training on the East Coast in Boston at Beth Israel Deaconess, where I also spent a year afterwards as a hospitalist there. Came over here because my wife did a psychiatry fellowship here, which is what brought me over to the Pacific Northwest. You guys are very much familiar with what UW-Montlake is about, but just quickly, we only here at UW only work at one primary hospital site. And at Montlake, there's probably close to like 35 to 40 hospitalists. And then on our direct care services, so on the non-teaching services, we have 4 direct care services.
Great. Thanks so much, Frank. And I think you bring that really unique perspective of having worked at 2 different academic medical centers. So appreciate that. Let's see, who's next? Jamie and Millette from Overlake.
Yeah, thanks, Gabby. So I'm Jamie Boswell, and again, joined by Millette Asmuth.
Hi, I'm one of the 2021 UW IM graduates, so I'm fresh out of residency.
She's the expert at rapid transition to your new fully adult life as a hospitalist. So thanks for coming. So yeah, Overlake, we're over here in Bellevue, and it's a 349 bed hospital. It is a team that I've had the pleasure of working with for the last just about 17 years. I came straight from training and really found a home, and it's been just a really nice fit to get to grow up professionally with the colleagues and the people here. Other questions you had asked about. So our ICU, we have 24/7 in-house intensivists. I really don't define it as rigidly open or closed, but it's mostly closed, I guess. The intensivists attend most of those patients, but I certainly can admit there should I wish to. All in all, yeah, we run, like a lot of the folks on the panel, busy service, 7 teams per day. We're a little bit smaller overall than some of the other groups. So our total team is 29 staff at a variety of FTEs, and that includes 3 APPs, and the rest are physicians. The physicians are a mix, predominantly internal medicine. We do have 1, 2, 3 family medicine trained team members. So I guess that's a quick overview of life here at Overlake.
That's great. Thank you, Jamie and Millette. Really appreciate it. Alan, you're next on my screen.
Okay. Hey, everybody. I'm Alan. I am in Millette's class, also a recent graduate. I'm currently a hospitalist at Valley Medical Center. We're a public hospital that serves South King County and the North Pierce County area. Super diverse population. We have an open ICU. I actually misspoke earlier on the earlier recording. We're actually a 331 bed hospital down south. Our group is roughly about 35 hospitalists, and 9 of them are nocturnists. And then the rest are just daytime hospitalists. And we are an open ICU, and I think that's mainly it, Gabby. Let me know if I missed anything.
Thanks, Alan. And I don't know if you said this, you graduated last year as well, right?
In Millette's class, yep.
Yep. So just trying to highlight that for folks if you have specific questions for recent grads versus folks who have been in their career a little bit longer. So I think it's helpful to have both perspectives represented today. Dave from Swedish.
Yeah, hi everybody. I'm Dave Wilson, one of the hospitals at Swedish. I came to Swedish right out of residency in 2014. So I've been with Swedish ever since, about 8 years. Swedish is a system of hospitals. We have 5 hospitals. 3 of them are kind of more community feel. 2 are more specialty oriented. One being kind of our cardiovascular and neuroscience institute area. And our hospitalist group covers all 5 hospitals. And so we have about 90 some physicians and APCs in our group, probably about 8 to 10 APCs, and the rest are physicians. We typically rotate at like a handful of the 5 hospitals. And so any given person will go to more than one hospital and be scheduled at different hospitals for their different week blocks. But typically not all 5, so that they can gain some familiarity with, you know, a couple of the campuses and not have it be too overwhelming to be at that many different places. It's one of the things that I love about Swedish is the opportunity to, you know, go to a smaller community hospital feel and then move to a bigger, more academic feeling place with a lot more subspecialties. We have mostly a closed ICU. We do have a nocturnist that covers the ICU at Edmonds currently, but for the most part, it's closed. We do have intermediate ICUs at our First Hill campus, and you can get some pretty sick patients there, but mostly closed. I think that's it for now.
Thanks so much, Dave. And did we catch everybody? I think we did. 1, 2, 3, 4, 5, 6. Perfect. Yes, thank you, everybody. Okay, wonderful. So I'm going to start with the same question that I started with in the last panel. And then residents, I'm going to turn to you and see what questions you have for our panelists, or feel free to send me a question in the chat. So the first question, one question that often comes up for folks is around teaching. So we have mostly community-based hospitals represented today, with the exception of Frank, Dr. Chi, who is here from UW. And so the question often comes up, what teaching opportunities, if any, are available in your different practice settings? And if you want to raise your hand or unmute, happy to have you start. Yeah, Alan, go ahead.
That's good. So Valley Medical Center has a family medicine residency program there. There are 14 daytime hospitalists, and one of those teams per day is responsible for teaching the residents there. It's a very different rounding structure than what we're used to at the U. The family medicine residents do pediatric rounds, OB rounds, and then do internal medicine rounds with us. So it's kind of divvied up throughout the day. The residents will carry about 5 to 6 of our patients when you're on the teaching service, and the teaching service is completely voluntary, so you can do as much or as little as you want, but it's always staffed by hospitalists.
Great, thanks, Alan. Maybe I'll come to Dave next, since I know that you have to hop off, and I know there are teaching opportunities at Swedish, so maybe you can share briefly before you turn off your camera.
Yeah, thank you. So at Swedish, we have a Hospitalist Fellowship for family medicine trained physicians. We have, many of you probably know, the Hospitalist elective for you all, 2nd and 3rd year UW internal medicine residents. We have 2 family medicine residencies, one of which we participate with some, and we also have Washington State University medical students. So our teaching opportunities are kind of opt-in opportunities, where we have one teaching service at our First Hill campus that supervises the fellow and would work with any UW residents that come through. They would also be the attending on any family medicine resident patients that are in the intermediate ICU. So that teaching attending has like a reduced census. They have some of their own patients, some that they share with their residents, and then they're supervising the fellow also. And then we also have teaching opportunities for 3rd and 4th year Washington State University medical students at our First Hill and Edmonds campus. And that's kind of a separate opportunity that people can opt into and be paired with a medical student.
Awesome. Thank you so much, Dave. Really appreciate that perspective. If I don't have a chance to thank you again, thank you so much for your time this morning. It's been wonderful to have you. I'm seeing some great questions in the chats from Kim and Judd. So let's finish the teaching question and then we'll move to that. So Jamie and Millette were next.
I'll take it this time. So Overlake is not officially a teaching campus. We don't have a residency or formal partnership with a medical school. However, there's certainly opportunities that come up for teaching if you're interested. So right now, one of my colleagues has been mentoring a PA student. There are sometimes ARNP students. There are definitely emails that go out for people who are pre-med bound who want to do some shadowing. So if you want it, there's definitely opportunities for it, but it's not a requirement as part of the job.
Great, thank you so much. And I remember from the last hour, one of the things, Jamie, that you highlighted that I think is something we don't often talk about is, having pre-med folks like in college and other like very early learners who enjoy shadowing opportunities. And that can be a really fun way to engage with learners as well.
Completely agree. That's another fun source of shadowing opportunities, and you get these really eager folks really trying to figure out what they want to do, and it's a fun part of the job, no question.
Thank you. All right, Nancy, you are next.
Yeah, so we support a third-year medicine clerkship from the university. Scott Stewart, who you guys may know, is the resident or the program director for that clerkship. We have 3 groups of 3 students between spring and fall. And you can either be a teaching attending or you can do lectures for the medical students. If you're a teaching attending, you have a reduced census to 12.
That's great, Nancy, thank you. And that, just as a reminder, is at Evergreen. And Sierra at Prov Everett.
Yeah, so Providence actually, in conjunction with WSU, just started an internal medicine residency 2021. So right now we have just interns, and next year we will be welcoming our second group. I think it's about 12 or 13 residents. So part of that is there are 3 wards teams that are very much like they were in the UW system. It will be a senior, 2 interns, and then either 2 UW medical students or 2 WSU medical students. And that is optional if you want to be the attending for the wards teams. That being said, the 2 to 4 shifts a month that you work swing, if there are residents that are on that shift with you, then it is the expectation that you are willing to teach them and staff with them.
Very cool. Sierra, I'm going to ask you to share a comment that you shared at the end of the panel last time around your aha moment that initially you were looking for a non-teaching career, non-teaching experience, and then there was something that shifted for you. So this seems like a nice fit where you have the option.
Yeah, absolutely. Thanks for reminding me of that. So when I was leaving residency, I was very much like, I just want to go work in the community, have that one-on-one with patients. I don't want to work with residents. I'm like not interested in that. And the shift to being not only an attending, but not being on a team where you have that group to bounce things off of, it is just you figuring out these patients, was a stark realization, which eventually after some months you adjust to. But that being said, I realized probably 3-4 months in that I actually did want to occasionally have that team back. So having the opportunity at Providence to do that, and it's not every month, but like right now I'm doing 3 months a year is the goal. It's been awesome, and it adds variety to the work that you do. So I highly encourage it.
Thanks, Sierra. Okay. We're getting some great questions in the chat. So I want to turn to that. Let's see. The first one I'm going to call out are Kim's. Kim, you had submitted the first question and then a second question. I'm going to see if I can maybe combine them a little bit. So the question, your second question is, what factors led you to accept your job versus others that you applied to, which I think is a great question. And then secondly, sort of maybe with that, when you were looking for a job, are there questions that you wished you had asked, sort of looking back in retrospect? Are there things that you wished you had asked that you didn't think about until after you accepted your job? And not everybody has to answer every question, but I'll open it up for our panelists. Looks like Nancy's got some thoughts to share.
Yeah, those are great questions. So when I was searching, again, I was straight out of university. What I liked most about Evergreen is the fact that we're self-governed, and so people in our group take turns being the medical director. I was the medical director for 4 years. We rotate that responsibility amongst everyone in our group. And so there's a real impetus to not only be fair across the board to everyone, whether you're in a leadership role or not for the time being, but also to try to look at the long-term sustainability of whatever decision you make for the group at that time. That was extremely attractive to me. And I remember walking through the doors, and part of my interview day was meeting the CEO, when I was like, okay, this is a good thing. We have a good relationship with admin. I think that was the biggest draw for me.
That is fantastic, Nancy. Thanks. Jamie.
Yeah, so I'll give this one a go. So I think I don't have as much for Kim's question, because I think I asked a lot of questions before I actually accepted the job. But what I was looking for was a job where I felt like people were very happy, where it was sustainable and people would stay in it for a long time, where there was flexibility in the work, where if I felt like there was something in addition to not just clinical practice, but maybe outside of that, that I could pursue, or at the hospital, quality improvement, or somewhere to figure out additional interest to integrate into the job. So I think looking at kind of what opportunities for career advancement there are, and seeing kind of at the group kind of what the general atmosphere is like. I think, you know, our group is very flexible, very collegial, and where there's like a good relationship with your direct supervisor. Jamie's an awesome boss, and I'm not paid to say that, but also like a good relationship with the hospital, because I think that affects a lot of the decisions that, you know, can affect your day-to-day work.
Awesome. Thank you.
Thank you, Millette. You'll be paid later.
That's great. Do others of our hospitalists have thoughts about that? What led you to accept the job that you accepted?
Sorry, Gabby.
Great.
So one of my top things was that I wanted to work at a hospital that served a population similar to Harborview, but that was not Harborview. And I definitely, so the 3 hospitals I interviewed at kind of had that mix of patients. Providence and Everett definitely has a diverse patient population, in that there are a fair amount of different ethnicities and languages spoken there. Everett, and we serve this huge area north of Everett. So there's a lot of low income, low health literacy, a lot of native populations people come down from Tulalip, which is really cool to get to know them and their culture. There's a lot of addiction medicine, there's a lot of psychiatry. So it's just really diverse, and you get to feel like, you know, you're helping a population that otherwise, you know, it does not always get the best care. And as far as when you said the question, as far as like, what do you wish you would have asked? I accepted my job pre-COVID, and then went into my job in August 2021 or 2020. So I had no idea what to ask or what to expect. What I will say is just getting a feel for the group during interviews, and is this a group that is warm and welcoming, and there's evidence during your interview that they actually like one another as people, was a really important aspect to me. And I definitely felt that at Providence.
Thanks, Yara. That's so helpful. Yeah, Frank.
Yeah, I mean, I chose to be at an academic center, mainly just for the variety of opportunities to pursue other outside clinical interests. So obviously there's a lot of opportunities for various teaching at the resident level, med student, in the medical school as well, just an abundance of things to get into different committees, QI projects. And then I think really important, just to kind of echo it's really about the people you interact with, because you are going to be, you know, seeing them on a daily basis. And so I interviewed again here pre-COVID. It's particularly hard to get the same feel when things are being done via Zoom and you're not able to see how people interact with each other. You know, when I look and came, you know, for interviews, seeing like, oh, do people eat lunch together? Are they mingling just, you know, outside of their little workspace? Those are the things that really gets you through, because it's hard to feel lonely and just like work a whole day by yourself. You really need people to help get you through. And I think part of that is also about asking about, you know, retention. I think there's a lot of burnout in hospital medicine, and people can combat that by doing outside clinical work or reducing their FTE. So I think also asking, you know, on average, you know, what percent FTE do most people work? Because that is another way to kind of gauge is, you know, 1.0 FTE, is it too much? And I think for many, you know, working 1.0 is quite difficult, and it is very common to be below that. And it's important to be able to understand and gauge it before you take a job. Certainly as a resident, you are so used to working so hard. So without a doubt, probably 1.0 FTE will be easier than residency, but as the years go on, it's very common to go down on that.
Thanks for that perspective, Frank.
And can I ask a quick question, Frank? Is it easy to go down on your FTE? This is for everyone.
Yeah.
Yeah, let's put that out to everybody. And I'm going to broaden that question, Jed, and then I'll come back to some of the questions in the chat. But I think it's helpful to know sort of the range of FTE and how people manage that. And that'll maybe segue to the next topic of work-life balance. So thanks, Jed. And I'll have Frank start, and then I'll go to the hands.
Yeah, very, very easy. I think when you work, I think as hospital medicine, it's probably one of the easiest jobs to like go down an FTE, as opposed to having your own panel and how that will work. So it's, I would assume, widespread, pretty easy to go down. Gabby, did you want me to talk about work-life balance, or wait for the next session?
Why don't we pause there, have other folks weigh in, and then
yeah,
we'll circle
sounds
back.
good.
Flexible. It's all good. Nancy.
So yeah, just as Frank said, it's one of the advantages, I think, of being a hospitalist is there's a great opportunity to vary your schedule. We don't generally, even for people who are 1.0, we try to stay away from 7 on, 7 off. Lots of people who are early career start there, and just because they've never had 7 days off in a row anyway, so they're pretty happy to have 7 on, 7 off. I'd say that I didn't drop my FTE from 1.0 until about year 18 of my career, after I was done with medical directorship.
You're blowing my mind, Nancy.
Nuts, I know.
Which is to say atypical.
I would say, yeah, probably is atypical. I'd say most people work 1.0 FTE for like 5 years or so. And then, you know, to be honest, if you're a woman and you having kids, it's really hard to stay 1.0. My husband made the decision to stay at home and leave his career with our children. And that was a hard decision for him and for us, but, you know, it was the right decision for us. I'd say that one of the things that attracted me to Evergreen in general is not only the variety of FTE, the ability to change your role also. So I've been the medical director, but I'm now the chair of medicine, of hospital medicine. And that really, I think, helps to answer the next question, combat burnout for me. So, you know, the fact that I've done a lot of process improvement in those roles and concentrated on things that are different from the day in, day out, seeing a large panel of patients, that's made it a bit easier for me, I think.
That's wonderful, Nancy. Thank you. Jamie and Millette.
Yeah, so we make our schedules quarterly. So it's possible to drop your FTE within a couple of months advance notice, so that contracts are not strictly like annual. So if something comes up and you need to kind of pull back, or if you want, and then we've had colleagues who are happy to step into extra shifts. So it's very flexible. The shifts, you guys will probably ask questions about scheduling and stuff later, but the way the blocks of time are structured, we have 3s and 4s that you can mix and match. So some of our more senior hospitalists don't want to do the 7 on anymore, and they're doing, more 4s. For me, I prefer working longer stretches because I find that easier, and so I usually work 7s.
Yeah, and I guess I would add to that. Millette summarized it well. I think it's one of the nice things in hospital medicine is there is a lot of flexibility. I have a partner who is in her 15th year here. I think she has had every single FTE level you can possibly think of over the course of that lifetime. And that's, she came straight from UW with her first child born between end of residency and starting with us that fall. And she now does a blend of palliative care and hospital medicine. So it's one of the really great things about a hospitalist career is that kind of flexibility to move up and down. And as we do, right, we all talk and we think a lot about things like burnout. That kind of flexibility is critical to kind of maintaining and sustaining people over the course of, what you hope to be a really long and successful professional career.
Thank you, Jamie. Sierra?
So I echo a lot of what other people have said as far as even when you're first starting, it's definitely not necessarily an expectation that you're a 1.0 FTE. Very few of the people who've been at Providence for 4+ years are a 1.0 FTE, I would say. Our schedule comes out, I believe, 3 months in advance. So it's kind of that if you decide to change your FTE, you'd be expected to work what's already on the schedule, but then thereafter, it's very flexible as far as dropping down that FTE if you want. Also a lot of flexibility, especially when you first start, you will work kind of the typical days rounding with a few swing shifts, which are primarily admitting and cross-covering thrown in. But like I decided that doing days for various reasons was not working for me. And even though I was the only one, I was like, what if I just wanted to do just swing shifts? And the medical director was like, yeah, let's try it. If you want it, I'm certainly willing to give it a go. And so I've been doing that since September and I've been loving it. And now I'm actually going to a nocturnist position. So when I decided to do that nocturnist position, it was very much with you're going to try this and it will probably work. And if it doesn't, then you're not stuck in it. They want to make sure that you're happy in the job. Similarly, you can be 7 on, 7 off. Most of the people in my group are not. So there's also that flexibility.
This is a really rich discussion, and I feel like sort of overlaps with a lot of some of the questions coming in the chat. And Alan, I want to call out your chat message also about the younger group of hospitalists at Valley. Most folks are 1.0 FTE, but large variation among the group. So I think just again, highlighting that things are really like life after residency looks a lot different, right? Like life is very flexible in ways that residency is like literally the opposite, right? So rigid, and you're told where to be and when and from what hours, and it's on a schedule. There's just a lot more flexibility, and Alan is supportive of that. One of the things that feels like a theme that we're talking around here is sort of work-life balance and sort of productive, healthy, meaningful, like longitudinal career. So there was a message from Luke in the chat a bit ago about factors in a hospitalist job that are most essential. Like what factors do you think are most essential to creating a hospitalist group with quality work-life balance, flexibility, and institutional support? I'm seeing Nancy has thoughts on that already, which is great. I think we're hearing a lot about sort of flexibility of scheduling. If there are other things, other factors that folks feel that we haven't talked about yet, please do raise your hand. Thanks, Jamie. And then also want to sort of add on this really important piece of like being explicit about work-life balance, especially for people who have families, regardless of your role as a parent, what kind of support there is there. So Nancy, let's come to you first.
Yeah, thanks. I think it's a really important question about work-life balance. I think that the most important thing for me as a hospitalist that makes me want to continue to come to work and be satisfied when I'm doing the work is having some degree of autonomy and say in what I'm doing and the patients I'm seeing. I find that especially as you get older and you're doing this for 10, 20 years, and I know that doesn't even seem like a possibility now, you know, coming out of residency, but that's what you want if you want to be a career hospitalist. What I mean by that is that it's a really different dynamic if, you know, you have a discussion with your administration and they say, you know, we have a problem with cardiology admissions. They don't want to admit anymore, because these discussions happen. How do you want to solve this problem? Or that's a very different discussion than people coming to you and saying, you're going to admit all the cardiology rule outs. And I find that the teams that have more say in how that is structured tend to have more longevity. You know, they feel like they're not being, and that's the truth with my team. I think we feel like there are problems ongoing that need to be solved as the practice is changing. And there are always difficult discussions. You know, how do you manage trauma as a hospitalist, or things that you haven't really trained for specifically? That community hospitals that are like our center is a level 3. And so we had to have a discussion about, you know, when we have geriatric patients that come in with flail chest, since it's an open ICU, who's going to, and by flail chest, I mean like multiple rib fractures, not necessarily an open chest.
I know, but still, it's like, you know,
your face.
Thinking about all the things that we don't have to deal with very often.
You know, who's managing that? And so we had to sit down with the surgeons and say, okay, you know, if you have more than X number of rib fractures, you're going to admit those patients. We're happy to help with, you know, medications and other medical management. So being able to have a say in what you do as a hospitalist, I think, is huge.
Thank you, Nancy. That's great. Sierra.
Our group is huge on work-life balance, and our medical director is great he very much cares about our mental well-being. And over the past 2 years, there have been a number of times where, for various reasons, some of us needed to be out for weeks or a couple of months, and he, even on incredibly short notice, has made it work because, you know, even in a really supportive, good environment, this is still a very hard job. It's a very difficult career in general that we've all chosen. And so that's acknowledged. And there's also very much the support from the team of when you need to step back for any reason, other people step forward and pick up shifts and things like that. And I think, yeah, just all the time, our medical director, even at times, will maybe encourage you to drop your FTE just you know, he definitely makes it known all of the time that he wants to make sure that you're seeing your family, that you're traveling, that you're doing the things that you enjoy outside of being a hospitalist.
Thanks so much, Sierra. And Jamie and Millette.
Yeah, I would echo what Sierra said. I think that preserving your happiness in your job and you as a person and your life outside of work is a huge priority, and I think it's really important. And I feel like that's very openly talked about, and I appreciate that. And I saw in the group that's true and it exists, because there's people who, I mean, we just had a night doc who's, after 20 years as a night doc, transitioned to a day doc, which is insane. I did not think that anyone could humanly do that. So I think that talking to people in the group and seeing that there's a lot of people who have been doing this for 10 or 20 years. And so obviously a lot of life happens in that period of time, and that the group has made that work was really, I think that spoke volumes to me. And Jamie can talk to more about I've only been here 9 months, so Jamie can talk more about how that exists, but the culture is definitely obvious.
Yeah, I think that's a very intentional process, and I think every institution works on culture, and every hospitalist group works on what is the culture of our team, and we work very hard to support each other and to be there. And I think if you practice, you know, for the next 20 years in a hospital, you're going to have good days and you're going to have some really tough ones. And I think, you know, just having people that you like being around, you trust them, you're willing to open up and talk with them, that makes a world of difference. And that's just the people side of it. I do think there are structural things. I think the way we build our schedule, as I always say, we build our schedule based on when do you wish to be off? When are the most important days that you want to be off? And then we try to make sure you get enough shifts to match your FTE built around that. I think there's a lot of pieces that you can do, but so much of it does start with the people. And I think that's just going to be critical, both now, historically, and in the future. That's really where it starts.
Thank you, Jamie. And Alan, I just remember from the last panel, you also talking about sort of the culture at Valley and the vibe of the hospitalists supporting one another. If you don't mind saying a word about that.
Absolutely, yeah. I want to echo what everyone else has said. Our group at Valley is also very collegial. We're oftentimes, actually, we just got a new team room that supports all of us within the same room. We used to be scattered kind of throughout the hospital. So now that we're all kind of in one place, it's always a safe place to talk, to vent, to bump ideas off of each other. And additionally, outside of our hospitalist group, we also have really great consultants, and they are more than happy to see any of your patients, even if you think it's a very silly consult question. So I think overall the atmosphere at Valley is very supportive. And I think the main thing all of us are trying to keep in mind is trying to take care of patients safely and well. And I think with the support of our consultants and our hospitalist group, we're able to do that pretty well.
Thanks, Alan. So I'm just kind of keeping my eye on the time. We have less than 20 minutes. So and there's one sort of big elephant in the room question that we haven't addressed yet, and that is salaries. And I know for our residents, that's on your mind, and it's a hard one to ask about. So I'm kind of giving a heads up to our panelists. I'm going to ask that question in just a moment. The other question that has come to me, and I think is a really good one we didn't address in the last hour, and that is around if applicants, residents, folks who are applying for a job, who have their own health concerns, health issues, may need a surgery, may have some upcoming need for medical leave that they're already aware of. How do you recommend folks manage that in the interview process? And that's kind of a hard question. And I realize that might be best pitched sort of to Nancy and Jamie, who both have sort of many years of experience in leadership in your groups. So if you might think about that for a minute and share any thoughts that you have. And anyone else is welcome to answer too. I just recognize that might be a harder question for new folks.
Yeah, I think that generally, if you're in a team that understands that life happens, then people cover for each other, and what goes around comes around, and everybody knows that. So, we had one team member, unfortunately, who went skiing and broke his pelvis, recently, and he's been off for a month and a half, and he may need more time, and everyone just steps up. He had PTO during part of that period, luckily for him, but there is a risk system, and we actually have periods of the year where we have two risks. One that people can volunteer for, and the second risk if they want to work extra shifts. We found that as our group has gotten bigger, the chances of someone being off, especially during COVID, for illness or for a family emergency are actually pretty high. If you have something that you're planning, like a major surgery, that goes into the making of the schedule. We tend to make our schedule a year in advance, and but it's not set in stone. People make trades all the time, depending on how things go. And people plan for family medical leave. They plan 3 months off for their maternity leave or their paternity leave. And so a little bit of forethought that works out on the schedule. Usually, if you don't have the pre-time and it's an emergency, generally people just cover using the risk system.
Thanks, Nancy. Jamie.
Yeah, no, thanks. I guess I think I would make the analogy to kind of how we talked in the last session a little bit about, if you're applying for a hospitalist position and but you're going to go off to a nephrology fellowship in a year or two. I would say just try to be as open about any concerns you have about any leave that you might anticipate, whether it's a delay in your ability to start. I think that's helpful to know. And again, I think also certainly being respectful of people's privacy in that respect. They don't have to confess everything. But I think just from the standpoint of just knowledge helps us all plan and helps us support them in, covering whatever time period or accommodation they might need. So yeah, I think, again, life will happen to all of us. I remember a distinct stretch where a number of us were going through, not thankfully personal health issues, but our parents, a lot of us similarly aged and our parents having major health issues. And so having to find ways to creatively help support us emotionally as we go through that. Also just logistically, making sure they get the time they need to be away if mom or dad is having surgery. And I'd make the same analogy if it was the individual hospitalist that needed those things too.
Thanks so much, Jamie. Sierra, and then I'm going to come to the salary question.
So it's awesome hearing from Jamie's perspective, basically what I would want to hear as somebody who is applying. And that was basically my advice, is just be honest in your interview. Because bottom line is, especially when it comes to like, if you're planning a pregnancy, if there's a major surgery, if you have, which obviously is on you of whether you want to share or not, but if like in our group, we have a couple people who are immune compromised, and just getting a sense from the group and the medical director, whoever interviews you, of how accommodating are they going to be to that? Because I would say, as much as you're interviewing for jobs, you are also interviewing these places because you are a great commodity. So you will likely have your choice of where you work, and you want to work somewhere where when you pose those questions, you aren't met with hesitation or anything like that. And you feel like even before you have decided to work there, that you're going to be supported in those ways.
Thank you, Sierra. Such a great point. And yes, our residents are commodities in a good way, in the sense that you will be wanted on the job market. So I appreciate that. So I'm going to try and wrap two questions into one that often comes up, and then we'll see how much time we have left. So I want to keep an eye on the clock. We've got a little more than 12 minutes. If you could talk about starting salary and sort of pay structure briefly for your hospital, to the extent that you know it. And the question I was going to wrap into that we talked about last, and panelists remind me if I'm forgetting, was around scheduling or no? Let's start with pay structure, pay and structure. Let's do that. How does that sound? And I'll let you know if I'm remembering what I'm thinking of. Jamie and Millette, maybe I'll come to you first since you're right next to me on the screen.
Sure. So the pay structure, so everyone is, all the hospitalists are paid equally. There's a base daily rate, which is slightly higher on the weekend shifts, but if, we distribute the weekend shifts equally. Then on top of that, the compensation is RVU based. So Jamie can speak to kind of what the average typically looks like, because this year the volumes have obviously been higher. And then in addition to the base and the RVU compensation, there's also a bonus, and part of that is made up of the group has some quality metrics that we're trying to meet. So those are, everyone's input goes into that equally. And then the other half of that is your own attendance of group and hospital meetings, as well as a project like a quality improvement project, or maybe you serve on a committee or some other citizenship function. Yeah. And I'll let Jamie answer kind of what that average looks like.
Yeah, I think, again, we don't have a salary, right? So it ranges even amongst people who are all at 1.0 FTEs, of which we have many. We have several at 0.8 and at other FTE levels. But I would say the average last year is probably about 350, and of course that's I think of our salary as pre-bonus. Our bonus is something that typically we work hard to achieve, but we achieve at a rather high rate. I would say 90+% of the available funds for that. And it is only intended to be about 10%, 10 to 15% of our total compensation. So, but yeah, that's a good rough number. It just depends on how many shifts you worked and how busy you were last year.
And the shift count for 1.0 is 165. And they separate the day docs from the night docs. So I only work days, and I work about one swing shift a month.
Perfect. That's exactly sort of the thing I was thinking about, Millette, is sort of how much work is required. Oh, I know, patient load. That's what I wanted to make sure, because it's very different, and understanding this salary and what you're expected to do for that salary versus other places.
Yeah, so we don't load level, meaning we don't like equalize the patient count per person every day. But that's where I think the RVU pay structure makes it equitable, and everyone, it just kind of depends on what your cycle is. But on an average day, I would say is probably 14 to 17. Some busier days can get higher, and then some easier days I've gotten below 10, and it just kind of works out where you leave a little earlier, or your colleague helps you out when it's really busy, because everyone's very collegial, and everyone, if you're having a hard time, I just say, guys, I'm really busy, can someone help out? And they take my overnight holdovers, and the RVU pay structure reinforces that. So.
Thank you, Millette. All right, Nancy.
So yeah, our base salary with none of the bonuses, and we're primarily salaried, is about 343,000 for a 1.0. And on top of that, there is a group productivity incentive. So we do everything. We do load level everything. We actually have an electrical engineer that graduated from the UW residency who made a program that we call the Hallucinator. So in the morning, it's Bob Clues, if you guys know him. We just plug and chug the numbers, including ICU patients, and everybody comes out even. We have a cap that we talked about where we will call in risk, and it's usually around 17 patients. That has happened a lot more during COVID, but rarely during normal times. Our above and beyond will be that group production that is split based on FTE amongst everyone in the hospital, and that's usually about 10,000 a year. And then you have the chance to do you get paid CME about 5,000 a year for going to pretty much anything medicine related. And then you can do committee work or anything that your medical director deems something that will help the group or the hospitalist. And that's paid at about 150 to 160 an hour. There are people who have medical directorships separate from the hospitalist group. There's a care management medical director, a QI patient safety medical director. The CMO of our hospital is a hospitalist. And so there's a huge push towards hiring people who want to do many things within hospital medicine. And I should mention 147 shifts per year for an FTE 1.0. And then above and beyond that, it's between 11 and 13 risk shifts. And you have a huge say in when those are done. So total is about 160.
Thanks so much, Nancy. Appreciate that. And it kind of speaks to one of the earlier questions about opportunities for non-clinical FTE at your institution. Sierra,
yes.
Load and salary.
So patient load, the goal is that everyone starts their day with 14, maybe 15 patients, with the idea that when you're just starting, that's your day. When you get more efficient and more experienced, you do 1 to 2 admissions a day in addition to that starting load. And then it's kind of up to you. People that are very efficient, or I'll talk about the pay structure a little more, but are looking for the more productivity, can have a team beyond that 15 patients, but that is definitely up to the individual. Our target salary and guaranteed in the first year right now is around 302,000. After the first year, and I would say even in the first year, the goal is that 50% of that is salary, 50% is productivity. So there's definitely a bell curve. People make far more than that. Some people make somewhat less. And in the first year, basically you are guaranteed whichever of the two is higher, either the guaranteed or what's based off your productivity. There's also team bonuses, there are project hours so that you are getting paid when you take part in committees and things like that. And there is CME. I'm not sure it's what it was when I first started. When I started, it was about $3,200 a year, and then it rolls over if you don't use it. And for the first year, the hours per a 1.0 FTE are a bit higher at 2,022. And then from years 2 to 5, that goes to 1,980 hours. And then there's the system of from years 5 to 10, it drops a number of hours, so on and so forth.
Awesome. Thank you, Sierra. Let's see, Frank, and then we'll finish up with Alan.
Yeah, so UW Montlake, the cap on any service is really 10 patients. So usually around 9 to 10 patients. And then in terms of salary, you know, it's noticeably lower at an academic center. So at UW, it's just above 200,000. Again, the balance is that lower patient load, and there's just I feel like I've worked in a community hospital before, so the days feel easier here. I have time like today to partake in things like this or other meetings or teaching opportunities. So I feel like my day is pretty flexible, and I can build in type of any of my outside clinical interests within my day at work, which is nice. In terms of it's straight salary, so there is no additional like RVU productivity. So it's kind of, you get the set salary. If you see less patients, you happen to have an easy day, or you know, I'm on a consult service now, and it's, you know, there's only 5 patients I have to see today, so it's like really relaxed. That's just how it is, and so you have really good days, and it makes life pretty nice.
Thanks, Frank. The nice days really help balance out those busy days.
Yes.
We can be honest about that too. Alan, do you mind wrapping us up?
Yeah, sounds good. So our daytime hospice 1.0 FTE is about 168 shifts per year. I think nocturnists are required to work 130 something, 132, I think, shifts per year with a little bit of a higher salary. Our patient load is roughly 12 to 17 patients per day, with about maybe 1 to 3 ICU patients, and then probably 1 to 3 admissions throughout the day as well, depending on kind of what admitting shift you are. All of us are salaried, so all of us have the same base pay of $320K, with a $30,000 bonus per year if you meet the individual and group incentives.
Perfect. That's super helpful, Alan. Thank you. And one thing that I mentioned in the last panel that I'll just say as well, from my perspective as being a hospitalist previously in the UW system and trying to understand the pay discrepancy as well. I mean, so there's a huge difference in the patient load is number one. And then the other perspective from the administration side, regardless of how you interpret this, is their perspective is, you know, some number of the shifts. So Frank mentioned 168 shifts per year, which is much better than when I was hired, and it was 184 shifts per year. So that's great. We're making progress. You know, a portion of those 168 shifts per year will be on the teaching services, right? So they're in 2-week blocks, whether that's 4 weeks, 6 weeks, 8 weeks, depending on your FTE. And so one could argue that that work looks fundamentally different when you're on the teaching, fully on a teaching service, as opposed to functioning as an independent hospitalist. Okay, let's see. 1 minute, 22 seconds left. So I'm wondering if there are any burning questions from our residents that didn't get answered, if I missed things in the chat from our residents. I tried to incorporate some different questions. Anything? Kim, looks like you have a question.
Oh. Do you guys have, like, when you're on, do you get paid if you get called in?
I'm gonna rephrase
call or whatever.
Yeah, Kim, sorry, we're having a hard time hearing you. You're cutting out. So I'm gonna give me a thumbs up if this is correct. Did you ask when you're on risk, do you get paid if you aren't called in, and how do you get paid if you do get called in? Is that right? let's go with that. Nancy.
Yeah, so you get paid per number of days that you're on risk. For a week block, you get paid $1,000 or something similar, $1,300 for if you're not called in. If you're called in, you get an hourly premium, so the base salary plus 20%. And if you're called in for a night shift, you get that plus an additional 20% per hour.
Great, thank you, Nancy. Anyone else?
I don't know if it was still going after this time ends. It looks like it will.
1 more minute.
I'm just wondering, for those that are in charge of these groups, what you look for in applicants.
Great question. Nancy and Jamie, that goes to you.
Sure, I'll jump in. I think the obvious is we want, hardworking, well-trained folks. And I think if it hasn't been said, the electronic room full of people there is just that. You haven't gotten to where you are without having put in a lot of effort, really shown a dedication to patient care. And we all have great confidence. As an example, we know our UW residents are going to be really well trained. So for me, a lot of it just comes down to finding people who, our kind of message matches theirs. Sorry,